come with a blood sugar level of 450 at the age of 35. So, you have confusion, type 1 or type 2. So, what I have told you, if there is confusion, give insulin. So, you first give insulin, settle the patient. Once the blood sugar level becomes normal, glucotoxicity has gone, lipotoxicity has disappeared, you test the patient for C-peptide. So, then you can come to know that what is the beta cell function of the patient. If the C-peptide level is less than 0.6, then naturally you should diagnose the patient as type 1, even though the antibody marker is negative. As I have told you, in a background, in our background, the antibody marker may be negative. More or less, as soon as means give 48-72 hours time. There is no any criteria out there. I have never seen that there is any criteria to do it within 72 hours or at least beyond 72 hours, nothing like that. So, what we usually do, we start the insulin therapy, ask the patient to come on the next week, something like that. We are not going to see the patient every day. We will ask the patient to come back after 1 week or so. If the patient is hospitalized, you have to take at least 3, 4, 5 days time to get the patient settled, and when the blood sugar level come down, normalized, patient is normalized, then you check for the C-peptide level. 0.6. It is the fasting C-peptide, but stimulated, we will talk later again. So, so in type 1 diabetes, actually they present very abruptly. So, usually if you get a type 1 diabetes patient, we can actually date the diagnosis of type 1. In the type 2 diabetes, on the other hand, you may find that a patient who is basically working in a multinational company have undergone a yearly checkup, and then it is detected that the fasting blood sugar is 192 and the postprandial blood glucose is 230, and then the patient land up in your clinic that the doctor, I developed the diabetes, and the diabetes has been recently been found when I underwent this medical checkup, routine medical checkup in my hospital or in my office. So, but in type 1 diabetes you will not find this. They will come with the symptoms because there is an absolute insulin deficiency. So, they will have all the symptoms, the polyuria, polydipsia, polyphagia, weight loss and pruritus. This is the 5 symptoms. So, they will come all 5 or a combination of 2, 3, they will come to you with these symptoms. So, naturally type 1 diabetes, actually we can date the onset of the diabetes. Okay, you have symptom, how long you are having this symptom? Doctor, I have this symptom for the last 3 months or 4 months, something like that. So, you know that the patient, if you have seen this patient in the month of April, that probably the patient has started the diabetes in not more than January 2015. So, patient has started the diabetes in 2015, maybe December, maybe January, that is a separate issue, maybe February also, but at least it has started in 2015. But in a type 2 diabetes, we consider that at least 5 to 7 years average. If a person is testing his blood sugar every year because the fact his parents have diabetes, so then you can date, okay, you are testing it for the every year and this year you are found diabetes, okay, so your diabetes started now. But in the majority of the situation, nobody has tested ever and will come to you regarding with one report and no any sugar done in his lifetime, and then we consider that probably he or she is already suffering from the diabetes for the last 5 to 7 years. This is the average, it is statistically. Maybe this patient has got diabetes only for the last 2 years, maybe another patient has got a diabetes for the last 10-12 years, but this is an average. We assume that the type 2 diabetic patient has got a diabetes for the last 5 to 7 years. So, type 1 diabetes, the deadliest complication of type 1 diabetes is the diabetic ketoacidosis. Why it is deadliest? Because the mortality is very high. Even in the Western society, the mortality is very high. In our country also, there is very high mortality of diabetic ketoacidosis, maybe in the range of 30%. Not a matter of joke. If we lose 30% of our children because of diabetic ketoacidosis, very bad, very bad. The whole life is in front of him. It's a small child, 5 to 15 years, and the patient landed into diabetic ketoacidosis, and the mortality is very high even with a good treatment. So, therefore, what is our objective of the management is that we do not want any of our child to develop diabetic decay. Not a single type 1 diabetes who is under your care should land up into decay. So, that should be the amount of care you have to give. Writing an insulin and keeping the blood sugar is one issue, but you have to answer the phone call of type 1 diabetes. For my case, actually my mobile number is all with all my type 1 diabetes patient, and if they call, I always respond. So, that should be your attitude. So, type 1 diabetes is a something serious. Whenever they call, you should attend the call, respond the call, and you have to give adequate advice, because sometimes what happens, young child, they may have faced some situation, say small accident at the time of in the playground, and this small accident, there may be some infection, and if there is a small infection, accident, and blood sugar is not controlled, patient will very quickly land up into an decay, sepsis and decay. So, you have to take the, you have a fall, okay, immediately check your blood sugar, what is your blood sugar, increase the dose of insulin, so that during this trauma period there will be a rise of blood sugar. So, immediately take care that rise of blood sugar, give insulin beforehand, so that the patient do not develop blood sugar level in the range of 400 or 500. And usually whenever there is a fever, whenever there is some sorts of infection or something like that, many people do not check blood sugar. Oh, this time the blood sugar, the patient is not eating well, so we are not checking, or something like that. Rather, this is the time when they should check more. That you have to emphasize. So, this is it. Then maturity onset diabetes in the young, which I have told you, the more or less age is 25 or slightly less. This is autosomal dominant, I have told you. That usually they do not develop ketosis. They may be managed with sulfonylurea, they may be managed with insulin in the later part. Genetic analysis is required for the diagnosis, which I have told you, but unfortunately not widely available in our country. They are usually obese. They do not need insulin initially, but later become insulin requiring. As I have told you, metformin is not the treatment. They usually have very mild form of diabetes, and MODY 5 is a variety where the patient may have renal cyst or renal agenesis. So, they are not very important to remember, but they have given it in this course. Now, type 2 diabetes in a young is also become very frequent in India. I have seen majority of the patient, they have both parent diabetic. So, if the both parent is diabetic, then the young child can develop diabetes in a teenager at the age of say 16 or 17 or 18, something like that. So, there is a strong family history. If the patient has got type 2 diabetes, there is a very strong family history that goes in favor of type 2 diabetes, young type 2 diabetes. And second, you will find the marker of insulin resistance, especially the obesity. Obesity is present almost invariably to every child who has. I have seen say 10 or 15 young type 2 diabetic, less than 20, 15 or something like that. So, all of them are obese. ALL, all of them are obese. You may find the other signs also, acanthosis nigricans, skin tags, that may be present. They usually have good beta cell function as it is measured by C peptide, what you have said, and the GAD antibody is usually negative quite naturally. So, that is why that is the way by which we may differentiate between type 1 and type 2, but as I have told you, GAD antibody negative does not mean that they do not have type 1. Yes, idiopathic variety hote pare. So, C peptide level normal and GAD antibody negative is